It's a little bit of overlap here. I'm going to wait till that goes to 10. Okay, so now we're going to segue directly into the endovascular management of thoracic and thoraco-abdominal aortic aneurysms. We heard a talk earlier today that was excellent, and there's a little bit of overlap here just on AAA, but a lot of similar concepts when talking about endo. And obviously in 10 minutes or so, we're not going to discuss all of this. All right, so let's talk about thoracic and thoraco-abdominal aneurysms. So the natural history of thoracic and thoraco-abdominal aneurysms in terms of survival is actually pretty poor. Obviously, before we started doing a lot of endografting, a lot of patients were followed and didn't have these repaired just because of the magnitude of the operation. But a lot of patients did die from ruptures, and a lot of patients died from the repairs as well. So non-operative management really wasn't favored, but neither was open management, which was not a particularly good situation if you were a patient with one of these lesions. This was a paper I wrote back in the peak of my academic career about 12 years ago. You can look it up. I had 30 pages in a row in JVS and invited commentary. Things were looking great. Dr. Lawrence shakes his head whenever he sees this now. Wonders what went wrong. But anyway, this was an interesting paper in my humble opinion, because if you followed patients who had open thoraco repairs, even for the year beyond, like for the first, you could look at 30-day mortality, which was commonly reported, and it would be, you know, whatever, 20% or whatever it was. But then if you followed them out for the remainder of the year and you were in your 80s, you had like a 40% mortality. And so even though we thought maybe we were doing a pretty good job with open repairs, getting patients out of the hospital, it turned out they kept dying for the remainder of that year. So endografting has definitely changed that, and I'm not going to rehash all of the numbers you've probably seen before, but certainly we don't have a 40% mortality at 1 year for patients undergoing endografting. So one thing that really, if you take one thing from this talk, it's the importance of pre-case planning. This is true, obviously, for open repairs, as we heard about with Mal, looking out for, circumaortic renal veins, things like that. But it's no less true, and possibly more true, for planning for your endo cases. And I think your endothoracic and thoracoabdominal cases, it's really, really important. Now, thoracic endografts, a straightforward thoracic endograft is like one of the easiest cases in vascular surgery, right? I mean, you can do it in 20 minutes. But at the same point, you might have to, you might spend 9 hours doing a case where you're working with branches and everything else. But even the simplest case can turn into a nightmare if you haven't really planned well. So even though we've increased dramatically the number of patients that can be treated with the endovascular technology, you really have to put in your hours and know what you're doing when it comes to planning. So what are the things that are important? You guys know all of this, right? And we heard about it in the talk on AAA, but access issues, even more important typically for thoracic cases because they tend to be bigger grafts than with AAA. You really need to pay attention to the risks of paraplegia, right? This is a devastating injury. And you really need to pay attention to planning your landing zones as well, especially the closer you get up towards the subclavian. So as I said, increasingly important with more complex cases. You want to make sure you have the right imaging, and you want to make sure you have all the tools you're going to need for a particular case. You want to make sure you have adequate landing zones. In terms of iliac access, we can talk about all these details, the degree of occlusive disease, calcification. The bottom line with access is if you think you might need a conduit, probably just do a conduit, right? I mean, we should all like doing, it's kind of like, and I'll get out of order on my slides here, but it's kind of like people who wring their hands and perseverate, which was an SAT word. I learned that for the SATs and I still remember it. Perseverate over whether to do a carotid subclavian bypass. And my response is always, why wouldn't you want to do a carotid subclavian bypass? You're getting an extra case and it's fun and everything else. But definitely, for those of you who have ever been involved in a situation with a iliac on a stick or any other problem like that, it's much nicer to just put a conduit on. So here's some pictures of different conduits. So what are your options? Certainly you can just put a conduit onto an iliac is easy. You can do an endoconduit as we saw before in the images. And occasionally for a thoracic case, we've even just done an aortic conduit where you can find a soft spot maybe on the aorta and put an infrarenal aortic conduit on. There's a picture there. So I would ask each of you, and I'm sure you do, each of you should become very facile at using one of these forms of like centerline and reconstruction imaging technologies, either M2S, TerRecon, Osiris, whatever you have available. How many of you do all your own imaging like that and can go through? And so looks like 6.4%. That's okay. It should be higher. You want to be in a situation where you can really do this yourself. And most of the software is really not that hard to use. You could probably go to your radiologist and sit down with them at their workstation and learn how to do it. But it really is very useful, and you get to really understand what you're looking at. You all familiar with this kind of technology, though? Once it's been produced for you, you can pick out. It's much easier to choose your landing zones when you're looking at these kinds of reconstructions. It's much easier to assess your access as to whether or not you'll need a conduit as well. We spoke about IVUS in the last case. How many of you are using IVUS for your thoracic stent grafts? Well, not that many. And it turns out only the really shy people are using it. I don't know if there's a correlation there, but anyway, yeah, it can be very useful, even if you're not dealing with, dissections or dealing with a fenestrated case. IVUS can be very useful just for assessing exactly where you are. And so I think that's a really good thing to practice whenever you can. TVAR steps, I don't need to go through these with all of you. I think most of you know these already. One thing that's very important is to go through your projections and have a sense before you start the case exactly how you're going to want to set up your gantry angles. It's useful to use the markers to sort of maximize them and make sure you have good exposure. But that's stuff on every single case you want to practice, and make sure you know what you're doing and you're understanding the angles you're setting up. So I'll just go through a simple case. 69-year-old gentleman with your usual comorbidities comes in with this nice-looking thoracic aneurysm. We always see easy ones like this. Just sort of stressing the importance, even on a simple case, of looking at your sizing, figuring out how much aorta you're going to cover. Do you guys all sort of know the magic number from the studies, the amount of aorta you cover, where you really get concerned about spinal cord problems? Anybody? Bueller? 19 centimeters, 70%, something like that. You want to have some sense of, if you're covering a lot of aorta, figuring out your proximal and distal landing zones, and then again, figuring out if you're going to need to worry about a conduit. So in this case, it looks like you have plenty of seal, figuring out how much graft. You're going to have about 200 millimeters coverage, so that's someone where you're definitely going to want a spinal drain. So before get the case going, you're going to know they want a spinal drain, and that's probably going to want a conduit as well due to the calcification in the iliacs. Most TVAR patients, again, just like with EVAR, they can go home very quickly unless there's any sort of problem. Usually get a scan within a day. And I think if there's no endoleak, you can be a little less rigid in following thoracic stent grafts than in bifurcated abdominal aortic stent grafts. So I usually follow them once a year after that. And obviously, if there's any problems, follow them more aggressively. The big things to watch out for are sizing errors, and again, we heard about that earlier. And then it's important to choose good landing zones. What I've seen with some frequency is patients who get compromised landing zones because people want to avoid the branches. They don't want to get too close to the subclavian, and so they try to sneak it in, or they don't want to distally go too close to the celiac. And like the aneurysm we saw in that other case that formed proximal or on top of the poorly placed stent graft in the abdominal aorta, you can end up with problems either above or below your graft. So it's extremely important. And then the bottom one, again, just talking about the use of conduits. This is just an example of bird beaking. This is actually from a dissection, but that's certainly something you can fix. This was fixed with a Palmaz stent, but it's very important when you're choosing your landing zone, if you're in the arch, to avoid that if possible. Sort of a talk in and of itself. So I'll just sort of zip through in my last minute and 41 seconds. We got to hear a little bit about fenestrated grafts earlier. One of the really exciting things right now, although it'll take away all those fun carotid subclavian bypasses that we all try to avoid doing, but debranching the arch, but then now having some fenestrated devices available. So for zone 1 of the arch, you can always do a carotid bypass and then carotid subclavian. How many of you have done these? Yeah, a couple. So those are fun operations, and it's a way to, again, to avoid a sternotomy. If you have a patient with zone 0, where you have to have, how many of you done these? Ascending bypasses and then coverage. This was popular for a little while, maybe like 5 or 6 years ago. There were quite a few people publishing series of these. I did several of them. It was very important to put your graft in from a conduit antegrade, so you weren't left with not having enough length to get up and around. But I think really what's going to take over a lot of these are as you all would be aware, either custom grafts or fenestrated grafts for dealing with the thoracic aorta. This is the Gore device that's coming out, the Gore C-Tag thoracic branch graft. There's a Cook device as well, and the Medtronic device. And these will all be things that I'm sure you guys will be using. How many of you have painfully used this eye cautery to do this? I'm assuming most of you. I know the talk earlier, they were saying we used to do these. I was like, damn, we still do them. Maybe with the time change, it hasn't gotten to Los Angeles yet, but we still, doing our back tables. And I used to think these were miserable cauteries to use when I worked in the ER and you had to burn through subungual hematomas and stuff. It's much more miserable doing these. They do take a long time, but anyway, you guys have all done these back table cases, and there's a ton of planning involved, but they get the job done. Just you all seen this. Skip through since we're running out of time. You can see the patient, other than his really hideous black box on his face, looks really good. Day after surgery. And then you guys have all used Z-Fens, I'm sure, as well. But this is really the future for you guys, is going to be this really incredible technology of being able to do fenestrated and branched cases. So what I would just stress to you is, even for the simplest of cases, the simpler the cases, the worse you feel if things don't go well. So you want to do as much pre-op planning as possible, and that's great training for when you start doing the more complicated cases as well. So anyway, I think we're right on time. Thank you very much.